Multiple sclerosis is an immune-mediated disease that can affect speech and swallowing of an individual. A patient admitted into acute care during an exacerbation or relapse would be seen by an SLP in order to assess any speech, language, cognitive, or swallowing impairment that could occur. Dysphagia and dysarthria are the two most common speech and swallowing deficits caused by MS. The SLP role is important in providing a piece of the differential diagnosis and helping patients have the best overall quality of life as the disease progresses. Multiple sclerosis is a neurodegenerative disorder that causes muscle weakness, tics, and can affect speech, cognition, swallowing, and language. 40% of those with MS present with speech and swallowing difficulties. Due to the highly likely occurrence of exacerbations, patients with MS will be seen in acute care, unlike most neurodegenerative disorders. ALS and PD are often not seen in acute care, and what makes MS a little bit different from common neurodegenerative diseases like those I just mentioned is that they have these relapses that cause severe symptoms, and they may or may not get better after a relapse. Each relapse can cause permanent damage, or they may recover, and that's why it's important. That's why we see them in patients with MS in acute care. SLPs will evaluate them for swallowing, speech, voice, and cognition problems in order to determine their safety and independence. After each exacerbation or relapse, it's important to evaluate if the patient has suffered permanent damage or is going to recover. You might not know this right away, but it's key for an SLP to assess where they are once their relapse has ended, and in order to assess their level of independence and if they can go home without any additional care. Multiple sclerosis is an immune-mediated process in which an abnormal response of the immune system is directed against the central nervous system. So the immune system actually attacks myelin and the nerve fibers, and eventually it damages myelin and slows or disrupts transmission of nerve impulses. So these nerve impulses can affect any area of the body, and that's why a lot of symptoms will be from hand movements, foot movements. They might be laying on the ground, kind of convulsing. You're really not sure what is happening. A lot of it you can describe as like a twitching motion, but during a relapse or an exacerbation, as I was mentioning before, all of this might happen, and a patient may just not be able to get up for 2 days, and they may recover. Recovery can mean that their symptoms slowly reside, or that they basically wake up one morning and they feel new, like they were before the relapse. Other people are left with permanent damage or permanent symptoms, and that's where speech therapists come in. So when any part of the myelin sheath or nerve fiber is damaged or destroyed, nerve impulses traveling to and from the brain and spinal cord are disrupted or interrupted, producing a wide variety of symptoms, as I just talked to before. So it's very hard to differentiate MS from different degenerative disorders such as ALS and PD. MS is thought to be triggered by genetics in the environment, and through some of my research, I actually found that people who living in colder climates are more prone to get MS. There's a big, high population in Canada that has multiple sclerosis, and they're really not sure. They think something having to do with genetics relating to cold environments may cause. There's 4 types of MS. There's relapsing remitting MS, and which is the most common disease course. 85% of people with MS are initially diagnosed with this type. What our MS is characterized by is they'll have little attacks that may last a few days, and then they'll have a recovery period where most of their symptoms reside, and they are just like new. Secondary progressive MS is the second most common MS. Most people are initially diagnosed after they have relapsing remitting MS, and this is just steady progression with or without relapses. So they do not recover after a relapse. Primary progressive is characterized by steadily worsening neurologic function from the beginning. There's no distinct relapse or remission, and only 10% of people with MS are diagnosed with this type. Progressive relapsing MS is the least common of the 4 types, And what happens is that they will steadily progress with degeneration from the beginning with occasional attacks. So unlike the other ones who may or may not have attacks, progressive relapsing, you will definitely have attacks, but without remissions. Common symptoms overall for multiple sclerosis are fatigue, which is the most common, and we deal with a lot as an SLP. You'll see how fatigue can affect speech and swallowing. They have walking difficulties, spasticity, muscle weakness, which is also a part of our scope of practice. Some may have cognitive emotional changes due to brain fog, since they're so tired, and a lot of medications can make it hard to think clearly. And speech and swallowing problems, a lot of dysarthria and dysphonia, as we will talk about later on. Those with MS are typically diagnosed between 20 and 40 years old. However, people can be diagnosed, earliest that I've heard is around 12. It's very hard to diagnose it since the initial symptoms are very common, and are suggestive of several other disorders such as ALS. And no single test can diagnose MS. It takes a few months to get a full diagnosis because there has to be significant damage in 2 separate areas of the central nervous system, at least 1 month apart. Patients will also receive spinal tap, blood work, and MRIs in order to pinpoint different lesions and where the brain is being affected. Patients usually have a normal lifespan, and it all depends on the severity of the disease and which type they have. The treatment for MS is usually medications that are only effective for those that have the relapsing forms of MS, and it just really reduces severity and frequency of relapses. They also receive speech therapy, OT, PT, neuropsychological treatment, depending on what stage of MS and what type they have. Some of the research that I found in regards to MS and acute care concentrated on the length of the hospital stay, how much money it costs to treat MS patients, and the different deficits that you may see in the hospital. So the mean length of stay for a hospital visit due to symptoms related to MS is 5 days. As you can see, that's a very significant number. SLPs will definitely be consulted in those 5 days, especially if they're presenting with problems with their speech and language. Cognitive deficits due to MS occur in 43 to 70% of cases during the early and late stages. Attention, processing, executive functioning, and long-term memory are all affected. Dysphagia symptoms in those with MS occur in 33 to 43% of cases, which greatly lowers their quality of life and often ends up being the most common cause of death due to aspiration of falling bronchopneumonia. Severe dysphagia like this occurs in late-stage MS, so it's not very common with people just being diagnosed or in the early stages. Swallowing symptoms are observed in the most severe cases, like I said, and it often coincides with severe brainstem impairment, obviously because the brainstem takes care of functions such as breathing and swallowing. A study done on the prevalence of dysarthria in those with MS determined that 62% develop mixed dysarthria with both ataxic and spastic symptoms, and the neurological symptoms of MS present in all 4 types of MS and at different times in the progression of the disorder. So there's not a lot of research out there about MS and acute care. I think it's a population that we don't really think of when we think of acute care. We think of stroke, TBI, dementia. And because ALS is not typically seen in acute care, you don't really think of MS being seen, but it is treated in acute care due to the relapses and the relapsing and remitting portion of speech and language problems. So the SLP role in acute care with the MS patient is to conduct swallowing screenings due to bulbar symptoms, chest infection, and difficulty chewing or swallowing. Speech screenings and assessment should be done if the patient presents with dysarthria, and cognitive screening assessment if the social behavior or level of dependence changes due to the neurodegenerative process. This list of tasks for the SLP was created by ASHA and is on the ASHA website, and it is our scope of care for those with MS. So the biggest effects on communication are, as I said, fatigue, dysarthria, and dysphagia. And some of the common symptoms that you will hear with people's speech with MS are scanning speech, slurred speech, and nasal speech. Scanning meaning their prosody, and pragmatics are kind of off. Slurred speech due to dysarthria or fatigue, and nasality is very high with this disorder. They also have tremors, head shaking, and incoordination, which can affect a lot of the speech and language. Okay, so dysphagia typically comes and goes in MS and is often very mild. So during an attack, the patient may present with dysphagia due to ataxia between breathing and swallowing, and just not being able to coordinate those two can really affect like choking and safety. So more severe dysphagia may present as the disease progresses, and this can lead to aspiration and life-threatening pneumonia. Dysphagia is most likely occurred to ataxia, like I said, and pharmacological dysphagia is high due to xerostomia or dry mouth. It's common with the many drugs treating MS, as well as a lot of drugs treating Parkinson's and other neurodegenerative diseases. I also, in an article, I found that MS patients typically present with esophageal dysmotility, even after oropharyngeal difficulties have been corrected. So most start out with oropharyngeal difficulties due to dysarthria or just general ataxia or poor coordination and weakness, and in the oropharyngeal muscles, but the esophageal dysmotility has to be due to the transmission of nerve impulses, since that highly relies on the vagus nerve. Okay, so dysarthria in those with MS is strongly correlated with demyelation of multiple systems and the standard progression of the disease. You will see this most commonly with patients early on because fatigue is so high. Patients typically present with impaired control of loudness, harshness, and articulation, and speech problems occur because of lesions in the cerebellum and demyelination in the brainstem affecting muscles used in speech. So you will see spastic dysarthria and ataxic dysarthria. The spastic dysarthria is due to bilateral upper motor neuron lesions and hypertonia, harsh voice, low pitch, imprecise articulation, reduced rate of speech. Ataxic dysarthria is due to cerebellar lesions and reduced timing and coordination. This is characterized by excess and equal speech stress, irregular articulation breakdowns, and distorted vowels. Dysphonia, which is very common with those with MS, may occur due to muscle weakness, spasticity, tremor, or ataxia of the vocal cords, and those with MS often become hypernasal. When nerve impulses are firing or slower and are not coordinating, your vocal folds may be hitting strangely or not really connecting, creating proper vocalization, and that's how dysphonia occurs. So MS and acute care. When we see MS in acute care, it's usually when patients are experiencing attacks or relapses, and we would see patients in order to assess their speech, language, cognition, and swallowing deficits. Not all patients recover from the exacerbation and may be left with new speech and language difficulties as disease progresses, and that's why counseling can become a big portion of acute care. So family members may experience similar emotions to the person with MS, such as fear, guilt, anger, denial, grief, and anxiety. And care partners often feel physically and emotionally exhausted, just as with someone with dementia. So it's important to counsel about neurodegenerative disorders, because they may not understand that while one day they may recover from a relapse, a patient might recover from a relapse, the next day they may not, or the next time they may not. And it's very hard to see someone for a few days, they are totally different, and then the next day they're walking and fine. But as the disease progresses, those remissions are not going to be as common or as successful, and they will eventually present with permanent speech and language swallowing deficits. So it is important to remember you must be aware of the speech, language, cognitive, swallowing deficits that can arise with MS, and it's very important to understand there are many paths of MS, and some patients will recover and some may not. This is an important time to counsel patients and family members about the different paths for MS and how another person with MS they may know is going to present completely different from them, and every patient with MS is very unique. You must assess the level of independence after every relapse, and that is the primary role of the SLP in acute care, and counseling again is very important.